Okay friends, so this gets us to our second part in CVS, that is blood vessels. Starting with blood vessels, starting with the first topic in blood vessels, that is vessel sclerosis. Starting with the first topic, that is vessel sclerosis. I can divide vessel sclerosis into three types, that is hyaline arteriosclerosis. I can divide it into three types, that is hyaline arteriosclerosis, hyaline arteriosclerosis, Monkeberg medial sclerosis, Monkeberg's Monkeberg's medial sclerosis, Monkeberg's medial sclerosis, and atherosclerosis, and atherosclerosis, atherosclerosis. So I can divide vessel sclerosis into three types: hyaline arteriosclerosis, Monkeberg medial sclerosis, and atherosclerosis. First point, starting with hyaline arteriosclerosis, we did this in detail in kidney. In kidney, we saw that hypertension affecting the kidney was of two types: benign hypertension and malignant, benign nephrosclerosis and malignant nephrosclerosis. Hyaline arteriosclerosis was the most common change, most common arteriolar change, most common arteriolar change associated with benign hypertension. It was the most common arteriolar change associated with benign hypertension. Not much concerned with this. Next, we'll do that in kidney. Next, this gets us to Monkeberg medial sclerosis. Monkeberg medial sclerosis is which type of calcification? We did this in general path cell injury. It is which type of calcification? What were the types? Dystrophic and metastatic. This is a dystrophic calcification. Monkeberg medial sclerosis is dystrophic calcification, dystrophic calcification affecting the where calcium is getting deposited in the walls of the muscular arteries, dystrophic calcification in walls of muscular arteries, typically involving walls of muscular arteries, typically involving the internal elastic lamina, typically involving the internal elastic membrane or the internal elastic lamina, that is Monkeberg medial sclerosis. Next point, before we go further, let us have a look at this slide. What this shows you is, this is a blood vessel. How do I know it is a blood vessel? It is a luminal structure. We are clearly able to see the presence of a lumen. This is a luminal structure with presence of RBCs in the lumen. It is a blood vessel. It is a blood vessel showing various layers of the muscle wall. Where is the abnormality? Abnormality is in the tunica media. Involved in the abnormality is in the tunica media, that is in the wall of the muscular artery, associated with calcifications. All these are the calcifications. So Monkeberg Monkeberg medial sclerosis. It is Monkeberg's medial sclerosis, which is calcifications in the tunica media of the vessel wall. Next point, these calcifications, do they obstruct the lumen? नहीं बचे, lumen of the vessel wall is intact, the calcification is in the muscle wall. So Monkeberg medial sclerosis does not affect the lumen. This does not obstruct the lumen of the vessel, does not obstruct the lumen of the vessel. As a result, is it clinically significant or non-significant? It is clinically non-significant. It is clinically non-significant. Lastly, increased incidence of Monkeberg medial sclerosis is associated with diabetes. Increased incidence is seen in patients of diabetes, systemic lupus erythematosus, SLE, and chronic kidney diseases. Increased incidence of Monkeberg's medial sclerosis is seen in diabetes, SLE and CKD. This is Monckeberg-medial sclerosis. Next, this gets us to the last vessel sclerosis, that is atherosclerosis. This is our main topic in vessel sclerosis, that is atherosclerosis. So starting with atherosclerosis, first point, this is the most common cause. Atherosclerosis, this is the most common cause of morbidity and mortality in the West. We lead a very sedentary lifestyle. We eat more junk food. I can't even remember the last time I went to a gym or exercise or whatsoever. So it is one of the major problems even in the Indian setup, in the medium and the higher socioeconomic status. So it is the most common cause. Atherosclerosis is the most common cause of morbidity, and mortality in the West. In the West. First point. Next, I can divide the risk factors for atherosclerosis. I can divide the risk factors for development of atherosclerosis into modifiable and non-modifiable. I can divide the risk factors into modifiable and non-modifiable. Non-modifiable risk factors. Non-modifiable is constitutive. Non-modifiable, that is, we cannot alter them. Non-modifiable or the constitutional risk factors. The modifiable risk factors, it's a very commonsensical table. This is more for the second years to write the question if it comes. Third year onwards, I'll come to your main points. Modifiable risk factors are hyperlipidemia, hypertension, smoking, alcohol intake, physical inactivity, physical inactivity and diabetes. These are modifiable, nothing to explain in this. Versus non-modifiable risk factors, just a sec, which are family history, genetic abnormalities, family history, genetic abnormalities, increasing age, stress. You very well know that there are two types of people: type A, which are the more aggressive ones; type B, which are the cool, happy go lucky people. Stress, that is type A personalities. And males. These are the non-modifiable or the constitutional risk factors. Nothing to remember. If you just see the table once, you will remember this forever. Next, next point, this gets us to the additional risk factors. For atherosclerosis. This is what is asked from third year onwards. Additional risk factors, starting with the first one, that is inflammation. The first additional risk factor is inflammation, and one of the main inflammatory markers is CRP. One of the main markers is CRP, C-reactive protein. Independently, C-reactive protein is one of the major indicators of ischemic heart disease. It is the most sensitive, CRP, it is the most sensitive for ischemic heart disease, IHD. Next, other risk factors are, this is also associated, the other risk factors for atherosclerosis are hyperhomocystinemia, hyperhomocystinemia. Next, increased lipoprotein little a, increased lipoprotein little a. It is written like this, LP small a, that is lipoprotein. You know this very well from biochem. Increased lipoprotein little a, Which is one of the main indicators of coronary artery disease? Lipoprotein little a, which is an indicator of indicator of coronary artery disease, indicator of coronary artery disease and cerebrovascular diseases, coronary artery disease and cerebrovascular diseases. So the other risk factors that we have seen till now are inflammation, hyperhomocystinemia, increased lipoprotein little a. Next is infections. Next risk factor. Next risk factor is infections. And which infections? That is herpes simplex virus, CMV, infections, that is herpes virus, CMV, and other infections. Last is metabolic causes. You very well know this. Metabolic causes: reduce good cholesterol, reduced HDL, increased LDL, total cholesterol, triglycerides, hypertension, insulin resistance. Reduced HDL, increased LDL and VLDL, increased LDL and VLDL, hypertension, insulin resistance, hypertension and insulin resistance. This was obvious. What you need to know in this table are 1, 2, 3 and 4, the first 4 causes, and if you just read it once you will be comfortable with it. These are the risk factors for development of atherosclerosis. Next point, this gets us to pathogenesis. This gets us to the pathogenesis of atherosclerosis. Why is atherosclerosis developing? The main pathogenesis associated with atherosclerosis is the response to injury hypothesis. Response to injury hypothesis. It is associated with response to injury hypothesis, which means that atherosclerosis is a chronic inflammatory condition. It is a chronic inflammatory condition, and the initiating event is endothelial cell damage. See, before I start writing this, response to injury. Endothelial cells got damaged, as a result of which neutrophils, macrophages entered into the bloodstream. They were already there. They localized to the site of the damage, got oxidized, leading to oxidized LDL and VLDL in the macrophages, in turn leading to formation of atherosclerotic plaque. So, response to injury hypothesis, so it is a chronic inflammatory condition. The sequence of events for third year onwards, the top 2 lines are sufficient. For the second years you can be asked a short note on this. Sequence of events is endothelial injury and dysfunction, which in turn leads to accumulation of lipoproteins, that is LDL and its oxidized forms. It leads to accumulation of lipoproteins, leading to monocyte adhesion, to endothelium, followed by, what are monocytes? They are the circulating macrophages. Macrophages of the blood are called as monocytes. Monocyte adhesion to the endothelium, followed by migration into intima, and formation of foam cells. This in turn leads to the formation of fatty streak. This foam cells and tunica intima, the migration of macrophages in tunica intima, This in turn is a fatty streak. This is the first feature or the initial change, initial gross event of atherosclerosis. This fatty streak in turn is associated with the lesion is progressing. The lesion is progressing, so it is associated with smooth muscle proliferation. It is associated with smooth muscle proliferation, smooth muscle proliferation, extracellular matrix production, extracellular matrix production, lipid accumulation, extracellular matrix production, lipid accumulation, and platelet adhesion, and platelet adhesion. So the initial cross change that we were seeing was the formation of fatty streak, which in turn progresses to smooth muscle proliferation, extracellular matrix production, lipid accumulation, and platelet adhesion This is the sequence of events. So for third year onwards, endothelial cell damage, macrophages come in, oxidized LDL foam cells leading to formation of fatty streak, which progresses to atherosclerotic plaque. Sufficient. The name of the hypothesis is response to injury hypothesis. This is the pathogenesis of atherosclerosis. Next point, vessels affected. Next point, vessels affected. Second years, any question on atherosclerosis, write everything that we have discussed and nobody will cut even a single mark of yours. Vessels affected. The most common vessel affected. Answer. Most common. Heart, coronary arteries. No. Most common. Aorta. Agreed. Which aorta? Ascending aorta, arch of aorta, descending aorta. Descending aorta is of two types, thoracic and abdominal. So most common is descending abdominal aorta. Most common vessel affected, descending abdominal aorta, followed by coronary arteries, which is the most common coronary artery affected. Most common coronary artery affected, left anterior descending. Most common left anterior descending, followed by popliteal arteries, popliteal artery is the most common peripheral vessel affected. Popliteal arteries, most common peripheral vessel affected. So see the language of the question properly. Most common vessel affected, just a sec. Most common vessel affected is descending abdominal aorta, whereas most common peripheral vessel affected is the popliteal artery. Next point, what are the spared vessels? Vessels which are spared are the upper extremities. Vessels of upper extremities, mesentery, vessels of upper extremities, mesentery, and renal arteries. These are the vessels which are spared. So we have seen this table both ways, most common vessels affected versus the vessels which are spared. Next point, this gets us to morphology. Of atherosclerosis. Morphology of atherosclerosis. First point, the first event, let me rephrase it, the first cell or the first lesion of atherosclerosis is the formation of fatty streak. The earliest lesion of atherosclerosis is fatty streak. It is the earliest lesion, which is composed of lipid filled foam cells. which is composed of lipid filled foam cells. It is the earliest lesion of atherosclerosis. Next point, these are what in color? What is the color of fatty streak? These are yellow in color. Yellow in color, 1 to 2 millimeters in diameter. 1 to 2 millimeters in diameter, present on vessel wall. Present on vessel wall. So 1 to 2 millimeter diameter lesions, small lesions are present on vessel wall. Do they cause obstruction to the blood flow? Of course not. This is fatty streak. They are very small, so they do not cause obstruction. Do not cause obstruction to the blood flow. Do not cause obstruction to the blood flow. This is fatty streak. This is fatty streak. Next point, fatty streak progresses to atherosclerotic plaque. Next point, the next morphology of the atherosclerosis is atherosclerotic plaque. Atherosclerotic plaque. So fatty streak progresses to atherosclerotic plaque, which microscopically which microscopically has three areas. That is the fibrous cap. It has three areas: the fibrous cap, the shoulder area, and necrotic core. Fibrous cap, shoulder area, and necrotic core. So atherosclerotic plaque has three areas: the cap, the shoulder, and the necrotic core. I'll show you what it looks like microscopically. Fibrous cap, this is composed of smooth muscle cells. This is composed of smooth muscle cells and collagen. Smooth muscle cells and collagen. Before I go further, let us do it the other way around. Let us first see what it looks like microscopically. Now this diagnosis you very well know. Answer: Monckeberg medial sclerosis. Which calcification was this? Dystrophic or metastatic? Dystrophic. You know that. Next, diagnosis. Now be unbiased. When you see this slide, you know that this is a blood vessel. This is a blood vessel in which the lumen is narrowed. Only this much is the lumen now. It is associated with narrowing of lumen. This is the narrowed lumen because of atherosclerosis, which has three areas: the fibrous cap, which is the dense blue collagenous area, dense collagen with smooth muscle formation, with smooth muscle proliferation. Fibrous cap. Then this is the necrotic core. Necrotic core, which is composed of all the cellular debris, lipid, foamy cells, and the shoulder area. And the shoulder area. Shoulder area is the most cellular area. So three microscopic areas: fibrous cap, shoulder, and necrotic core. This is atherosclerotic plaque. This is an atherosclerotic plaque. Next point. So let us write whatever we have discussed. Microscopically, it shows us three areas, which are fibrous cap, shoulder, and necrotic core. Fibrous cap is the composed of smooth muscle and dense collagen. Shoulder area, this is the most cellular area, and contains macrophages, T cells, and smooth muscle cells. Macrophages, T cells, and smooth muscle cells. That is the shoulder area. Last is necrotic core. Which is obviously deep to the fibrous cap, and contains cellular debris deep to the fibrotic cap and contains cellular debris, lipid, lipid and foam cells. Lipid and foam cells. So once you see the microscopy of atherosclerosis, you will never forget the areas, the fibrous cap, shoulder and the necrotic core. This is the microscopy of an atherosclerotic plaque. So in morphology, we saw that the earliest lesion was the fatty streak, which in turn leads to formation of atherosclerotic plaque. Next point, atherosclerotic plaque can be of two types. It can either be a stable plaque. It can either be a stable plaque or an unstable plaque. Stable or an unstable plaque. First point. More is the fibrous cap. The thicker it is, more stable will it be or unstable? Stable. So stable plaque has a thick fibrous cap versus unstable where it is thin. Next point, inflammation. Inflammation. The more severe the inflammation, more unstable it is. So inflammation is severe and unstable, whereas it is mild or minimal in stable. Last is necrotic core. Necrotic core is again thick and unstable versus stable where it is thin, a thin necrotic core. This is stable versus unstable atherosclerotic plaque. Stable versus unstable atherosclerotic plaque. If the atherosclerotic plaque is unstable, if the atherosclerotic plaque is unstable, it can in turn rupture. Rupture can be associated with ulcerations, hemorrhage and thrombosis. If the atherosclerotic plaque has undergone ulceration, blood enters into that area, as a result of which hemorrhage and thrombosis, leading to complete occlusion leading to complete occlusion of blood vessel lumen, leading to the complete occlusion of the blood vessel. Next point, unstable plaques, it can even break off and embolize to distant sites, that is atheroembolisms. Atheroembolisms are common. This is stable versus unstable. So what we have seen in atherosclerosis is we started with the pathogenesis, saw the vessels affected, the vessels which are not affected, the hypothesis associated with was response to injury hypothesis. Then we saw the microscopy, the three regions, fibrous cap, shoulder and the necrotic core. Then we came on to the stable versus unstable and the sequences or the sequelae of an unstable atherosclerotic plaque.